Let's get started with our first session. The first three presentations are broadly going to address the topic of the chaplain's involvement and role in medical decision-making. And I'm going to introduce all the presenters and our respondent for this session, and then let them come up one by one and make their presentations. So we're going to begin with a presentation by Jeanne Wirpsa. Jeanne is a program and clinical ethicist for the medical ethics program and a research chaplain in the spiritual care and education department of Northwestern Medical Center, Northwestern Memorial Medical Center here in Chicago. So did you hear what I just said? Yeah. Jeanne is a research chaplain. Have you heard that term before? Right. You will actually meet several people today who actually have that job description. And that's a new development. Probably 2 years ago, there probably wasn't anybody with a title like that. So it's part of the transformation that we're seeing, and we're very excited by it. Following Jeanne, Aoife Lee, who is the Director of Spiritual Care and Mission at Rush Oak Park, will make her presentation. And then following Aoife will be Dirk Labuschagne. Dirk is a graduate of our residency program and former palliative care chaplain, the first palliative care chaplain at Strozier Hospital, which is the county hospital just next door here. And Dirk is now one of our Transforming Chaplaincy Fellows in his second year of his MPH, enjoying Biostats 102 and Epidemiology 102 and all those good things. The respondent for the first session is Dr. Sean O'Mahony, who's Associate Professor of Hospice and Palliative Medicine here at Rush and Director of our section of Palliative Medicine, and we're really grateful that Sean could be with us to be the respondent. Jeanne, come on up.
Back, hear me? Excellent, great. I'm Jeanne Wirpsa, as George said, and I'm happy today to present on our research looking at the role of chaplains in medical decision-making with adult patients with serious or life-limiting illness. And to start, I just want to acknowledge my research partners. This would not have happened without them. I'm glad to be here getting all the glory today, but they should get as much as I. Our research is located in 3 sets of background literature, which I'm going to invite for you to look at the several slides that follow right now. I don't have time to go over them. But again, the shared decision-making and interprofessional shared decision-making literature, what chaplains do, and what we know about the status of religion and spirituality as it impacts medical decision-making. Our study. So we knew something going into our study. We knew at least that chaplains are involved in medical decision-making in some way. Kevin Massey's taxonomy demonstrated that chaplains often are involved in aligning the medical care plan with patients' values. But we didn't know much about how they do that, what that looked like, and what the barriers to that involvement were. So that was the goal of our study. With 3 phases to the study, I'm just going to talk about the first phase today, though I will say our book's been accepted by Kingsley Press, and hopefully, if we get it in on time, should be out by APC conference next year. So the first phase of the study, we sent a survey to many chaplains. Anybody here to fill that survey out? Take part in that? No, interesting.
It was a long time ago.
It was a while. It was. And we sent that via the major certifying bodies to, again, look at frequency of involvement in decision-making, barriers to decision-making, and some specific activities that we had designed. We designed the survey with the help of focus groups, research review, and then we piloted it for face validity at one of the APC conferences and then disseminated that. So what you're going to see today is really the result of that survey. It's a mixed method study so that we had both open-ended questions, which I'll share with you. We did some qualitative research as well as some close-ended survey questions that we could calculate with the help of Pat Murphy, who is now retired and not here today, but we were blessed to have her on our team. So The first result, we asked chaplains about the frequency of time they spent in this area. And again, we asked them to look at their clinical time, because we know that chaplains do a lot of other things, manage departments, direct students, but we wanted to know within your clinical time, how do you think about this area of your care? And interestingly, over 45% said that they spent a lot of time in this area, more than we actually expected. We then had identified 6 specific activities or ways in which chaplains supported medical decision-making, and we asked a similar question: how much of that time is devoted to these specific activities? And these activities, again, were gleaned from the research that we had done and the focus groups that we had conducted. And the first area that received the largest response in terms of time allocation was supporting the emotional processing of medical decision-making, followed by communicating patient values and other factors that contribute to medical decision-making to the medical team, clarifying with patient and family what are those factors that impact medical decision-making, assisting with advanced directives, educating patients and families specifically about things like what is CPR, what does brain death mean, and then finally mediating family conflict and conflict between the patient and the family around goals of care, again, direction that care is going in. All of these activities were highly correlated. So in our analysis, we actually wound up lumping them together under a category we called integration. If Pat were here, she would explain to you what the Cronbach's alpha 0.86 meant. What I see here, just looking at how these other activities relate with the advanced directive, assisting with advanced directive activity, was that one way in, advanced directives often leads to involvement in these other areas. And specifically here you see, it's not surprisingly, the high rate of involvement in educating patients and families about specific things like what does DNR mean, what's CPR, et cetera. We asked about a number of variables that impacted the outcome we were looking at, which was what is the degree to which chaplains are actually integrated into the decision-making process. And so again, in order to figure out what integration meant, we came up with these 3 questions. I find it easy to communicate via these various methods. I'm always included in healthcare team discussions, and I feel welcomed. And the only one where we were troubled by was the fact that even though chaplains felt welcomed and felt like they could communicate, they actually weren't at the table. And so again, you'll see this coming up over and over again in our research literature, our results. We asked about a number of factors that impact that level of integration. Among them, things we'll see shortly: race, ethnicity, religious affiliation. But 2 that we isolated and asked chaplains about were how well prepared, how well trained are you to contribute to this area, and do you have the time you need? And again, chaplains felt like, these are self-perceptions, that they were indeed very well prepared. They had received the training they needed at whatever stage of their career, but that they really, many of them did not feel like they had the time. And this theme of not having the time will come up significantly and be fleshed out in our qualitative data. So as I said, we asked about a number of variables that impacted this outcome of how integrated chaplains were, including race, ethnicity, gender. None of those seemed to make very much difference whatsoever. They were not statistically significant, with an exception I'll share momentarily. We did ask about frequency of decision-making and integration around work setting, because we thought, well, maybe people at a community setting are more involved in this area because there's not an ethics program or palliative care. Made absolutely no difference whatsoever where you worked. The one exception to that is if you worked at a religiously affiliated institution or not. And again, you can see here that there was a trend with some of those integration ways to be, again, involved in different aspects of decision-making depending upon your location. Where we did find a significant difference was in the level of experience of chaplains. Now remember, we only sent this survey to people through certifying bodies. So it'd be folks who were either on their way to certification or who had been certified. We didn't include residents and students. Among those who were less than 5 years and then greater than 5 years, we did 5-year increments. There's a huge difference in the level of integration. And as we went up, over 21 years of experience, you were 389% more likely to be involved in this area. Again, we can speculate together at some time about why that is. We also asked about, were you a designated chaplain? So to a specific team. We isolated ICU, thinking this is where decision-making would take place. Oncology, also thinking, wow, lots of big, serious life-changing decisions going on. And then finally, palliative care. And again, once we did our multivariate regressive analysis, what we came out with was the only area that made a difference was oncology. And those chaplains were actually 55% less likely to be involved in medical decision-making. Again, we can speculate together later about why. Very busy slide. I'm not going to review it. You have it. Well, actually, you don't have it. If you'd like it, I'm happy to send it to you. And it will be published shortly in the Journal of Healthcare Chaplaincy. So as I said, this was a mixed method study. We asked 2 open-ended questions and received over 400 free text responses, some short phrases, some lengthy paragraphs, some multiple stories, about these 2 questions. What prevents you from being involved, and what do you think chaplains uniquely contribute to this area? And for those of you who've done mixed method studies, I will say I love it, because the quantitative data tells you one thing, but this kind of puts flesh on the bones of that and allows those of us who are especially more narrative persons to kind of delve deeper, get a sense of what's going on, and I think provides more room for us then to do some follow-up research studies on a larger scale. So I'm just going to share this one slide, the next few slides, if you get them later, thank you. We'll flesh this out. But the main areas where folks identified barriers were in terms of, on my notes, 25% of the, again, responses that we looked at the domains and then categorized them and did a statistical analysis to see how many, what was the frequency of those domains. 25% said that communication and timing was the main reason they weren't involved in decision making, meaning we just didn't hear about it. We weren't there. The decisions happened before we got to the table. The second area had to do with system issues, so staffing ratios. I'm stretched too thin. I cover 5 units. I'm in the middle of a care planning conference and I'm carrying the on-call pager, so get paged out. And can't therefore fully participate. And then the third area was the understanding of the chaplain's roles by other members of the team, and specifically the narrowing of chaplain's roles to someone who only sees religious patients, prays, and of course comes only at the time of death to offer after the dead body is there. So skipping these next 3, because I only have 20 minutes. What do chaplains uniquely contribute to this process? These are the domains that arose as we did coding of all these analysis with the coding team, and again we did all of the usual methodology to ensure that our code book and our coding was accurate and representative, again what we were looking at had some consistency. And these are the 6 domains that came up. What I'd like to point out is that some of these actually overlap with those 6 discrete activities that we had previously identified, and some don't. So again, in terms of qualitative research, adding another layer, especially around what I'm going to call the approach that the chaplain takes, a very different sense from what the quantitative data could capture. Let me just share some of these domains with you. I'm not going to read all the slides. So first of all, the domain that rose up was something about chaplains having a spiritual lens and being a spiritual presence. Resonate? Right. So, but how did this contribute to medical decision making? Chaplains integrated prayer into decision making. They attended to spiritual distress that was, again, impacting decision making. they held a sacred space in which decision-making could take place and have it be less scary. And then once a decision was made, through ritual, through prayer, through presence, blessed that decision. Chaplains, not surprisingly, offered their insight and their guidance around specific religious and ethical frameworks, and were able to, because of their cultural competence, clarify for patients and families within their own denomination, within their own faith tradition, what the range of options were. We're able to, again, help be a bridge around some of the cultural differences and clarify those and then share those with the medical team. Remember I talked about the attention to emotional burden, the supporting the emotional processing of decisions in the quantitative data. Again, we saw that show up here. A lot of this was about not just attention to emotions like guilt, anger, fear that we know can, again, impact decision making. The long-lost son who's been in California for 2 years and comes in and is playing catch-up and feels bad because he hasn't seen his dad forever. But the emotional burden of decision-making, just what is it like as a surrogate decision-maker, as a family member, to have to make these really hard decisions for someone else in the context of great uncertainty. Chaplains talked a lot about their narrative competence and the way in which being trained in narrative methods allowed them to pay attention to not just the story and hear that, we do that for a long period of time, but being able to lift up out of that story what really mattered to a patient, what quality of life actually meant, what the values were embedded in that story, that life history. Chaplains talked again a lot about this role that we see, which is mediating family conflict. Again, less frequency than some of the other domains, as with the activities that we did the quantitative analysis on. And this is where it got really interesting, is where chaplains talked about the specific approach or process that they bring. That because we are not, we don't have an agenda, we can go in and, again, kind of slow down the process, have the ability in a compassionate, sensitive way to ask hard questions, that we bring something else to the medical team and to this process that other members of the team don't always bring. And then finally, and this was an interesting domain, that what struck us when we looked at the responses in this domain were the metaphors that people used about chaplains' roles. That chaplains serve as liaisons or communicators. They're bridges, they're mediators between patient and family and medical team. We're a neutral party, we're non-medical, right? Impartial, which was different than the folks who would come in with their agendas. We serve as translators, two ways. What does this value and religious belief mean? How do we make sure the team knows that? And how do we help the patient and family understand the medicalese or the jargon or the way in which physicians or the medical team approaches a problem or things? We coach, we nudge both sides again, and we advocate for patients' voice to be heard. So our conclusion was that 3 major barriers are addressed within what we call shared decision-making by chaplains, or chaplains are positioned to address these if we address some of the ways and the things that keep them from being involved. That the lack of attention to religion and spirituality by other members of the healthcare team, and again, the research supports this. During family meetings, people bring it up, physicians don't even notice it. The lack of attention to patient stories and values that are embedded, again, within those stories. And this incredibly fast pace of the medical culture and this increasingly fragmented doctor-patient relationship, interdisciplinary team, multiple players. So what does this mean? How do we conclude? How do we help position chaplains to be integrated into shared decision-making or interprofessional shared decision-making? We obviously need to do some education on the role, both among ourselves, with administrators, and with our colleagues. We need to look strongly at staffing ratios and how coverage assignments are aligned. And then we need to really seriously begin together with our colleagues to look at interprofessional models. What makes for collaborative care? How do we not just work in silos? How does the EMR contribute to that success? Limitations, first of all, with adults only. With patients who have serious advanced illness, I'd love to see a study done on chronic illness, chaplain's role in that, beginning of life, fertility, decisions about pregnancy, termination, lots of rich soil there. Again, we focused on the United States, unlike some other studies, just because the role of the chaplain was a little bit more standardized. And this was, again, a self-perception. This is what chaplains think we do. What do our colleagues think we do? And was there a selectivity bias in those who, again, decided to participate in the survey and the study? Future research, for those of you who are here because you want to do that, lots of opportunities. Again, as I said, what are the perceptions of the patient and family and other healthcare members about our role? What should we have? What role should we be taking? Is there any objective data in, like, through a chart review on when we're involved and what difference that makes? Does our actual involvement help provide value concordant care? Does it in any way impact length of stay, if we care about that? What is behind this experienced chaplain level of integration, right? Why do we think that it is that experienced chaplains are more likely to be involved in this area? Therefore, this area that we think we have so much to contribute in, we get to maximize. And how do we perhaps help our junior colleagues, again, have more of that skill set if we in fact think this is an area where we have a lot to contribute? What's about this dedicated oncology chaplain? Why are they not as involved? Right? Have we done much research on especially outpatient cancer care and the integration of chaplains into that setting? And then finally, if we were going to work towards interprofessional collaboration, what's the best model to educate our colleagues? Is it shadowing? Is it didactic? Is it sharing these kinds of studies with them? Is it sharing case studies with them that we're about ready to publish on these areas? So lots of future possibilities for those of you who are ready to jump in. We'd be happy to collaborate. Thank you. I thought you were.
We'll bring you back up.
Perfect.
I'll bring this way down and hope that you can hear me at the back and get accustomed to my voice. My project, as I listened to you, is to help us. One, I'm going to be telling the story, not so many paragraphs and all of that, and two, it's also to encourage folks that research can be done in a small bite. So the research that I did, and I'm going to turn this a little aside so I can see this, was part of my being a Coleman Palliative Medicine Fellow. I was in the second cohort where they had chaplains and social workers as part of the group, along with physicians and nurses and APNs who were studying palliative care here at Rush in collaboration with Dr. O'Mahony and Dr. Stacey Levine from the University of Chicago. And obviously none of this would have got done without the support of the Coleman Palliative Medicine, so I'll say that up front. I was here at Rush, I did my training here, but I work at Rush Oak Park Hospital, which is a small community hospital about 7 or 8 miles west on the 290, and it's part of the Rush system. So really what I was trying to do, having worked for many years in ICUs and with patients at that end stage, my goal was palliative medicine is not something that happens at the end, excuse me, but if we can introduce the idea of palliative approach to managing life's limitations in terms of the length of life that one might have. But just that awareness that, you know, life comes to an end, so let's sort of think about it a little sooner before we're already in ICU. So I was looking to try and have values-based healthcare decision-making happen in the outpatient setting, in the doctor's office, with patients who were visiting their doctor as kind of a regular visit. So in order to do that, we had to set out criteria. I also had to work on building up relationships, but I had already, I think it's significant to put in there that I am 18 years here at Rush, and that means that I know a lot of physicians and a lot of nurses who are now junior nurses or junior physicians and have become leaders now within the Rush system. So I had tremendous support from my colleagues that I've known, but that relationship building helped me to actually do this piece of research. So I set out a criteria of the patients, 3 things: that they were 70 years or older, that they had decisional capacity, and that they did not have an advance directive in our electronic medical record. So there were the three very basic pieces. This happily was a quality project rather than research that would have needed an IRB to go to and all of that, which meant that I avoided a lot of the problems that real researchers or major researchers have to go through. And I was able to identify one particular physician that I worked with over this period of time, and again, it's somebody that I've known for a long time, and who therefore helped me to onboard the staff and all of that. So the actual collaboration was very important to me in all of this. The building up and drawing from long-time relationships with folks, and being able to bring together things like getting Epic sorted out, because you have to be able to chart. There's no point in, well, no point totally, but the idea was that this would be in a medical record for future reference. And very often in my conversations with a patient, I would say, you know, this is not for now, you're doing fine, but it's a good thing to have in place, so the same 5 years or 10 years down the road, you know, Dr. McGee will be able to just press a few buttons and pull this up, and she'll have an idea of what your thinking was when you were well and able to walk out of the office. So that's very much my approach in my conversations. More to that in a few minutes. So as I say, Oak Park is down the road, so it's affiliated with here. That too was also an important part, that the doctor herself is a long-time family practice doctor who was beloved by her patients. I say that because I built upon their trust. For those of us who are bedside chaplains, we know that part of how we get connected with the patient and family is because we become an extension of the relationship, of a trusted relationship with their physicians. If we can do that, we're going to get a lot more depth into our conversations, because we will have somehow we'll be part of the trust that is there for the physician. So again, as I say, I had to build up all sorts of relationships and get buy-in from all the office staff in order to be able to do each part of this. I'm going to try and go through this fairly quickly so I don't use up my 20 minutes with too much detail. The education, now it's a couple of years ago that I actually did the project, and I've continued to do some of this work in a number of our different offices, which are adjacent to the hospital. So it makes it possible, like many folks here, as a chaplain, I'm employed by the hospital. I work mostly in the hospital side of things, so to be able to run across and be adjacent to the doctor's offices made this project feasible. But it's really important to have everybody on board. If you're doing research, all the office staff, from the front desk person who's going to scan the document in a timely fashion, and to everybody, to have everybody on board, and everybody then feels they're involved. In fact, one of the pieces that I found very helpful in being in a sense embedded in a hospital, in an office, was I had time to sit there with the staff and start conversations with those. So I've helped some staff think through what sort of decisions they should have in place for their own elderly parents or sick family members. And I've helped some of our other physicians and younger physicians who didn't have as much knowledge about advanced directives as I thought they might. So a lot of informal educational pieces were going on. So let me go through some of this. One of the other parts of this was that I kind of scanned the doctor's patients that were coming in. And so I weeded out who were not part of my criteria, and I identified the ones that I wanted to meet with and let the doctor know. She agreed, and she made the introduction in the office setting. So she set up my meeting. The other part of this, and this goes to why you have to work with everybody in the office, was because once the physician had seen the patients, most often I saw the patients after the physician. It depended, sometimes I might see them before, but that just depended on the situations. I stayed in the exam room. So the doctor would go in, do their exam and all the rest of it, and then introduce me, and doctor left the room, and we continued to hold that room for the patient who didn't have to move. So part of that, because I found in other places and a couple of other occasions where the staff want to say, I want to keep this exam room for only the doctor to be in, move into the next room, and in that move you can lose the patient and lose the opportunity and lose momentum. So that was an important factor that I was able to manage that helped with all of this. Another key part in this is the how I engage the patient. I gave you a little example earlier on, but it's a values-based conversation. So I try to help patients to look at their life experience. I know I've been asked, how did I manage to do this? You'll see as I go through the slides. The average amount of time I spent with a patient or the patient and family was 24 minutes. So generally speaking, it was somewhere most frequently 19-20 minutes. And in order to be able to get to the nub of the conversation, get to some meatiness of the conversation, I wanted to draw upon their experience of people in the ICU, if they have had any experience of having somebody in the ICU. And that obviously was that to me was the biggest impact upon folks. If they did have experience of that nature, it probably had a bigger impact than canonical law coming down and saying you must do this or you must do that. People's own experience was really what dictated a lot of their decisions, or indecisions, I guess, too. This was very much focused or based on the advanced directive of a durable power of attorney for healthcare. Part of that was, well, we needed to focus for the sake of research. I had to keep a fairly strict focus on what I wanted to achieve. Mostly it was also a non-threatening kind of conversation. I'm not looking for people to make end-of-life decisions. I was helping them to try and identify and to understand the importance of identifying a trusted person to make their decisions. So that often would come out of the conversation. At times, for example, I know I had a patient who herself was just in her early 70s and married, and she said, well, my husband is. And I said, and how's your husband? Oh yeah, Dr. So-and-so was saying they're thinking he might have early stage dementia. And I thought, well, no, that's possibly why it's a good reason that maybe your husband wouldn't be your decision maker, that maybe now you start to look at somebody else being that decision maker. And that type of, aha, was not infrequently did I find that to be the case. What have I got here? So in doing that, so I would do the document with after the conversation, try and complete a document, and then have that scanned in. But they always maintained or always retained the original document, and if they told me they had 4 or 5 kids and they had named one power of attorney and they'd named 3 others as subs, I gave them 4 or 5 copies. All the time, part of my conversation with them was to encourage them to talk to their families. So if I did not complete a document with the patient, they went away with a blank document so that they had something to begin to discuss with their family, and at least we had begun a conversation of some sort. Right. Okay. So I get to results. Finally, I get to this part. So my study was in a very set period of time. It was April to October of 2016. I had worked through getting these which patients to work on, and kind of decided during the course of that time that 60 would be my number, which was about a third of the patients that were eligible, a third of the patients in the doctor's practice that were eligible for the study at that time, and 100% of folks agreed to see me, which I think is testimony to the trusting relationship with their physician and that being extended to me. About nearly 4 out of 5 completed the actual dual power of attorney for healthcare. So actually executed the document, which was very satisfying, obviously, but it wasn't the total aim of the project. And as I said, about 24 minutes. So it is the different conversations that came up. It was possible to have significant values-based conversations, even in that relatively short period of time, in the doctor's office. And I think part of what happened also is that these 3 different responses that I picked out were very much the kind of the general piece. Either some people never talked about it, didn't want to talk about it, in a sense were a captive audience there for this period of time. They were probably the ones that brought the 30 to 40 minute conversation. They were the other end of that, this 15, 16, 17 minute conversations, because a lot of the time we were just chatting about all sorts of things in terms of values. And so they never talk about it, and now here they are talking a little and saying that it was very hard to talk about it, but they were willing to do so, and they were very appreciative of the fact of bringing it forward and having, even if they didn't complete the document, having a tool to help them have conversation when they left the doctor's office. And then some folks actually very clear. I mean, there were a couple of cases, in fact, among the 60 that would have signed a pulse document, especially if these were patients who were like 80 and 90. I had a dancing 92-year-old come in and say, oh, you just keep moving, just get, oh, darling, I'm 182, for goodness sake, what are you going to do to me? And don't let them touch me. And those ones, I actually went back to the doctor and I said, this one's pretty clear. She wants to be DNR. and we completed pulse documents and sent them home with lots more documents, and we had a lot more in place. That would end up, I know that we have certainly helped folks to avoid some of the medical interventions that are possible, because we've had this conversation. I've been able to follow a few cases where that has been the case and the person has passed peacefully in their sleep the way they would have wanted. I also found, for those of us who are chaplains again, that the religious piece was not necessarily the biggest influencer. It might have started out a little bit like that, and they might have said that to be the case if you had only talked about that, but really the biggest factor was their experience. So I found it very important to me as I went through it to really touch on folks and ask them their experience. And the other piece in this was that so many folks don't get to talk about their experience. We're so quick to, it's like you're dead and that should be the end of it. and they don't want to talk, family don't want to hear about it anymore. So we gave people opportunity to talk about their experience of lost loved ones in that, and to document those who were clear. All right, I just see him holding up the thing. So I'm come to my penultimate slide, because the object of the question was, from a research point of view, was is it possible to have a values-based healthcare decision-making conversation in the doctor's office? And my conclusion was, once you set up the whole circumstances and you build on the relationships, yes, it is possible. And I continue to do some of that. It's a work in process, and we will be researching more of that. Just to show that we do have some, I did have some sort of data with the help of George for the most part. And this is the published piece with George and Sean and our other colleagues from the Coleman Palliative Medicine. We were fortunate to be able to publish this piece in JAMA Internal Medicine. I think I'll end there. A couple more slides.
Hi everyone, I'm happy to be here with you, and I'm thankful for this opportunity to share with you about this study. So I have to just acknowledge, just briefly, all the names that you see on the following two slides, especially George, Lexi, and Daniel, who really continues to be the driving force behind this study. But then also Christian Schenk, who is here at Rush, and then also the site directors and research assistants who are at the other 4 sites that are part of this study. So this is where I hope to go with this presentation. As you can see, this is a work in process. So some of this data is still being captured, hopefully as we speak. And the findings I will be presenting today is the data that's been collected up until a point about midway through the summer, so about mid-July. And I'll say more about that as we get through the presentation. So we all know that chaplains are involved in the ICU, and there's a key assertion about chaplaincy involvement that underlies this study. So for the loved ones of patients with advanced illness who are admitted to the ICU, experienced chaplains can offer the kind of support and care that helps to align their treatment decisions in the ICU with the values of their loved ones, whether those values are religious or otherwise. And furthermore, chaplain involvement can help loved ones understand that decisions for comfort-focused care can be consistent with their love for and their responsibilities to their loved ones. So in turn, this can reduce the aggressiveness of care that they choose in the ICU, as well as the length of the ICU hospitalization. And there are several studies that support this, and we'll just briefly look at a couple of them. So in 2012, this study by Kevin Flannelly and others looked at more than 3,500 US hospitals. They found that having chaplaincy services were associated with significantly lower rates of hospital deaths compared to hospitals that did not provide chaplaincy services. And similarly, having chaplaincy services were associated with higher rates of hospice enrollment. So as you can see there, those associations were relatively small, like for those beta values there, but they do point to an important role that chaplains can play in terms of these important outcomes. Will Fond and others found in a study of 46 surrogate decision makers that religious considerations were important in making these difficult end-of-life decisions. The authors concluded that these complex religious considerations need to carefully be attended to by clinicians, which further emphasizes the unique role that chaplains can play in this area. So we are aware also of efforts to determine whether certain interventions or specialized clinicians can have an impact on outcomes, such as the ICU length of stay. So the table there on the screen, this is a systematic review of such efforts in palliative care that was just recently published. As you can see there, the various studies show different effects on the time patients spent in the ICU based on whether they were part of the control or intervention group. And for the most part, the review found that patients with a palliative care consultation in the ICU, when compared to those who did not have such a consultation, showed a trend towards reduced length of stay. Which brings us to our study. So the study had two aims or goals: to describe the spiritual care provided by chaplains to ICU patients and their families, and to examine the association between chaplain spiritual care and some of these important end-of-life outcomes in the ICU. So one of these outcomes is length of stay, so number of days in the ICU. And so we're wondering, can spiritual care impact the length of stay and potentially the aggressiveness of treatment that families choose? And so in this regard, we hypothesized that compared to the ICUs where spiritual care is provided by a CPE student, in ICUs where spiritual care is provided by an experienced, well-integrated staff chaplain, there will be a shorter length of stay for patients. And the patients we'll look at here are patients who either die in the ICU or are transferred to hospice, and I'll say a little bit more about that later. So from here on out, you'll see the findings that I show would show numbers for groupings of staff chaplains, or staff chaplain sites, or student chaplain sites. And with that I mean, there are specific hospital sites where we felt like, or where predominantly the spiritual care is provided by either mostly student chaplains or predominantly by staff chaplains. And as you can see there, the hospitals with student chaplain coverage are Rush and Penn Medicine, and those with staff chaplain coverage are Beth Israel, Indiana University, and St. Thomas. So moving into the methodology. So as you can see there, the dates that we used to include patients into the study are the first three, or earlier in 2017. The three categories that we used as inclusion criteria is that the patient would have had died in the ICU, or the patient was transferred or discharged from the ICU to a step-down unit where they received care mainly focused on comfort and end-of-life measures, or the patient was discharged from the ICU to hospice. And it looks like we'll have about 300 patients once all the data has been captured, which is about 60 patients for each site. As I mentioned before, we kind of had a cutoff date for the findings that we're going to show you. So for the findings I'll show you today, we're working with 139 patients. The data was collected from the electronic medical records. We captured data around patient demographics and medical conditions. We looked at the care that they received while in the ICU, and then also focused on specifically the spiritual care and palliative care that they received and what that care looked like. We also captured data around the chaplains that provided the care, the basic demographics, but also their years of experience and their specific position in the ICU. And then also institutional and spiritual care information around how many beds in the ICU, and then also what the chaplaincy care and the involvement in the ICU looked like. For example, was there a dedicated chaplain for the ICU? What kind of things did they respond to? Were there certain protocols where certain care was expected from chaplains? And then in terms of the primary outcomes and secondary outcomes, we did look at the length of stay, as I mentioned before, but then also some other outcomes such as code status, palliative involvement, and the advanced care planning. So now we'll move into that first study aim that will be describing the spiritual care that was provided by chaplains in the ICU. And before getting into those findings, and kind of looking at the big picture of those results, I want us to focus and kind of zoom in on just briefly 2 cases. As we think through how chaplaincy involvement can impact our outcomes, I think it's helpful to first look at some individual cases. So as we do so, I also want to invite you who are also in clinical settings to kind of think about your own patients and your own involvement in these kind of settings. If we would capture what you're doing in the ICU in the way that I'm going to show you, think about what that would look like. So the first case there is Fred, which is not his real name. He is a 49-year-old white male. He came to the ICU from the emergency department and spent about 32 days there before he died. So I know this is a bit of a busy slide. As you kind of orient yourself to it, let me take a sip of water. So as you can see there, we are listing the 13 chaplain visits that happened over the course of those 32 days. And we mark what happened, what kind of activities happened during each visit. So perhaps unsurprisingly, most of the things that happen are the emotional and spiritual support, spiritual assessment during the first visit, some prayer ritual provided, and then towards the end of his life, some support before, during, and after the death of the patient. And then when we think about the kind of things that chaplains would do that would have an impact on these outcomes that we're looking at, we feel like what would be particularly important is those involvement in goals of care conversations, perhaps something around advanced care planning, or sitting in on family meetings and participating in family meetings. And in this particular case, you can see that goals of care conversation did take place, as well as, some family meeting participation, but it's not the predominant activities that chaplains are involved in, specifically in this case. Another case that studied, Terry, a 54-year-old white female. She came to the ICU from the post-transplant floor after already having spent some number of days in the hospital. She ends up being in the ICU for 5 days before she dies. The chaplain support there, she received 3 visits over the course of those 5 days in the ICU. And as you can see, most of that is, again, kind of emotional, spiritual support, some addressing of spiritual distress. Perhaps the chaplain helped the priest to visit the patient or family, and then mostly support around the patient's death. And so this case is an example of the kind of average support that we see chaplains provide the patients in the ICU. Most of the patients there tend to spend about 0 or 1 to 5 days in the ICU, and this tends to be the kind of norm. The first case that I showed you is more of an exception of both someone spending that much time in the ICU, but also the chaplaincy involvement there. So now that we've looked kind of at the individual cases, I'll look at the more big picture results that we found. And as I mentioned, now we'll kind of have the sites broken down by coverage mostly by student chaplains compared to coverage mostly by staff chaplains. And we do see some differences there. As you can see, for the staff chaplain served sites, a greater percentage, 24% of the patients didn't get any visit, where it seemed like the staff chaplains were a little more dedicated. Only 13% of the patients didn't receive any visits. And as we move more towards the 3 visits or 4 and plus visits, it does seem like the 2 kind of catch up with each other. To kind of give us an idea of the reasons for visits, who received the care, and then also the activities, we kind of focused on the first 2 sites, the first 2 visits that the chaplain gave, and again comparing the 2 different sites with each other. And again, some differences are there. So it seems like about almost 50% of the visits from the staff chaplains, from the student chaplains, happened because they received a referral from a staff member on the site. Where it seemed like more of the visits from in the staff sites happened through the chaplain's own initiation, which kind of speaks to some of those differences we expect from student chaplains compared to staff. Perhaps student chaplains have more group work that take up their time. They're not able to kind of embed themselves as fully into the units as staff might be able to do. And then again, in terms of the care provided, most of the activities during the chaplain visits evolve around providing emotional and spiritual support, providing some ritual and prayer. And then again, those that we are kind of interested in, the goals of care conversations, family meetings, those kind of things aren't happening as often as we might hope. Then moving into our findings around the primary outcomes. I know that slide is a little bit dense, but let me just argue a little bit. So that first histogram we see there focuses on the staff chaplain sites, and we kind of have a line there. If you can see it, it starts at 0 days, so it focuses on the length of stay in the ICU. So it moves from 0 to 20, and then even 40. And then the percentage of patients who spend a certain amount of time in the ICU. So for the staff chaplain sites, we see the biggest percentage of patients spend about 0 to 5 days in the ICU, and that those numbers kind of drop down as the length of stay increases, and we see some cases even past 20 days, and one even past 40 days. For the student sites, a little more of a variety, but also the majority of the patients spend less than 5 days in the ICU, with none of them really longer than 20 days. And then looking at that box plot below, it's kind of that last two graphs there. If you can see it more towards the right, there are those little kind of circles out there. We refer to those as outliers. So one of those, kind of the midway point between 20 and 40, is probably Fred, who we looked at, who spent about 32 days in the ICU. So if you think back about our hypothesis, where we were thinking that staff chaplain sites would have a shorter length of stay, those patients would have a shorter length of stay. Well, when we want to compare those two with each other, those outliers are kind of creating a problem for us, because we can't really fully measure what the effect of quality chaplaincy care is on length of stay, because of our data being so skewed. Even though, in this case, the medians for both sites are 4 minutes long, not 4 minutes long, you know where my focus is, 4 days, 4 days spent in the ICU, we can't really see that strong effect that we would ideally want in terms of the length of stay in this regard. So just briefly, some of those other outcomes we looked at. About 20% of the patients who enter the ICU have a healthcare power of attorney, which is quite low, but perhaps unsurprising. 80% go into the ICU being full code. And in terms of the code changes that happen, from full code to DNR, about 75% of the patients do receive that switch, with some differences between the student sites compared to the staff. And similarly, in terms of transfer to hospice, it does seem like there are also some differences. Almost 40% of the patients in this student chaplain sites do end up going to hospice, and a little lower in the staff sites. And this might involve palliative care involvement, and as you can see there, not a big difference between the different sites in terms of palliative care involvement, but some there in terms of how long that involvement stays. In terms of where we're going with this next, so this is the kind of study that we did without having a budget. It is possible, everyone did contribute to this on top of everything else that they have going on. And so if that's something that's of interest to you, please get in touch with George and ask about how one goes about doing something like that. I mentioned the challenges of the length of stay and those outliers. Our next step is kind of thinking through how to address those. One of the things we're doing is kind of reducing the comparisons to patient level, maybe seeing if patients who mainly receive care from staff chaplains compared to student chaplains, if there are some differences there. We also want to look at the consistency of care in terms of the spiritual care that is provided, and maybe thinking through whether the emotional support, is there something to, like Jeanne mentioned, is there something to the emotional support and how that can help people to maybe be more clear-headed or help them connect to the values, as we mentioned, to make those decisions more easily. We hope to conclude the capturing of the data within the next month, hopefully, and move towards writing manuscripts and also receiving more funding, hopefully from the NIH. And then just a little something about my own involvement in all of this. That's not quite how intense it was, but sometimes kind of jumping into situation, it was a very steep learning curve for me. There's a lot of catching up I had to do. I did this as part of my field placement at Rush, but it was very satisfying to have this real world environment where I can apply all the work that I've learned through the first year of my work and collaborate in terms of the problem solving and thinking through the issues that we encounter along the way. So for anyone that has that burning question that you need some answers to, research is the way to do that. So reach out to others, colleagues, network, become involved in the workshops we have. I can highly recommend it. Thank you.
Presenters, and was interested in some of the disparities in the findings between the three different studies and the similarities as well.
Louder, please.
Jeanne, you mentioned that the number of years of experience is associated with the extent to which chaplains are involved with shared decision-making and values-based decision-making. Could you posit as to why that might occur?
So what we heard in some of the in-depth interviews that we did as follow-ups was that folks who have been around, who speak the language of their medical colleagues, who are more trusted, really are, that's the foundation that allows for more integration. This physician, the attending, knows me, trusts me, knows that I'm helpful, has learned more about what chaplaincy is, knows, again, the full scope of my skill set, and so therefore is likely to include me. So mostly has to do, again, with being known, not only, again, being more familiar with the medical setting, but being trusted then by the medical team. That would be my, again, based upon what we heard from our colleagues.
So I think that speaks to findings from other large-scale studies, such as the support study, where the intervention had a lack of impact, and one of the big reasons was that the intervention nurses in that study, they were using nurses to present information in regard to prognosis to attending physicians in the ICU setting, were unknown to the physicians, so they associated less weight to the data that was presented to the physicians. You also mentioned that oncology chaplains are less likely to be involved in shared decision making, and it seems somewhat counterintuitive based on the potentially high mortality and short survival time of many of those patients. Can you opine as to why that might occur?
So I worked as an oncology chaplain for 10 years, and I will say I was very actively involved in medical decision-making, as you can imagine, and had a background already in palliative care and hospice chaplain. So I'm probably the outlier on one of those graphs. I think it has something to do with the fact that a lot of cancer care is received in the outpatient setting. And if we think about how siloed care is in the outpatient setting, unlike your study where you partnered with someone, a chaplain will go by and see people on their own in the transfusion center. The chaplain, if they're even in the outpatient setting, again, will be called in specifically to address spiritual needs, and I think is not recognized as being able to contribute to this area. In the inpatient setting, I have no idea. Again, I think it could have something to do with the turnover of who the attendings are, but again, you have that in the ICU. Maybe residents cover more of the oncology care. It doesn't add up. So I haven't given it a whole lot of thought. It could have something to do with the nature of oncologists and their kind of where our medical practice is right now in terms of, or where oncology practice is. All these new, immunotherapy drugs coming out, so many more life-saving options are put on the table, and so there are fewer and fewer conversations about where are we going to draw the line, and a lot more ambiguity and uncertainty about what really is prognosis and what can we impact. Speculation.
So I think you hit upon the lack of knowledge of other healthcare providers as to what chaplains do. So I think conducting research with healthcare providers on what areas are addressed by chaplains, I think will be pretty important at maybe advancing the integration of chaplains into these conversations. Aoife, I think it's very striking the amount of time that the meetings took. They're very similar to the amount of time that physicians who have been recorded having these conversations, about 20 minutes. But one of the critiques of how we have these conversations is how little we listen to patients in regard to how their experiences matter and how their values matter in regard to decisions that they make. What proportion of the time in these meetings was spent reflecting back on their values and experiences?
Well, a couple of things, Sean. I think proportion of the time is probably 90% of it in relation to their experience and their values. I'm giving 10% over to kind of very social conversation more than anything else. I think one of the factors that is often not addressed clearly enough by chaplains or by the medical field is patients' expectations. So what I've found over the years is that patients expect the doctors, the oncologists, the different specialties to fix them, and they don't expect them to be coming in talking too much about end of life. They're expecting you to do something that will fix me in some shape or form. Whereas with chaplains, you walk into the room, even if the patient is pretty healthy, they still think, oh my God, am I that bad? And so building upon the patient's expectations allows for the kind of sets the tone for the conversation. So I want to say that 90% of my conversations in that short period of time was, this person's kind of confused as to why is there a chaplain coming in to see me after my doctor? I'm here to see the doctor. And getting an explanation for that, and then that just very quickly they open up to talk about their life experiences with some guidance and coaching and open-ended questions and that sort of thing through that time.
So I'm struck that maybe the next study that you should be doing will be looking at the patients and families' experience of these conversations when a conversation is conducted by a physician versus when a conversation is conducted by a chaplain.
Thanks, Sean.
Also, just to reflect upon the pragmatic nature of this intervention and how generalizable it is to real-world settings, of the potential patients who you could have recruited, you recruited about 35% of the patients. And just to put it in context with research that's funded by national entities, so we have a PCORI-funded study going on in the Cancer Center right now, and we've reviewed over 300 potentially eligible patients just to recruit 2 people. So that perhaps reflects how some of the research that gets published in major journals presents findings that are not really replicable in the real world. So I would encourage you to continue publishing on your findings.
Okay, thank you.
Dirk, I noticed that you didn't have exclusion criteria for outlier length of stay, but in the medical literature in palliative care, I think routinely people will not include people with very short length of stay versus people with very long length of stays, i.e. lengths of stay over 30 days. So what was there any thought to removing some of the outliers when you're conducting analyses on the?
Yeah, I think that's helpful to know that happens. Yeah, I think we did think through how to move forward. Is there a way to determine just like you mentioned, we would be unrealistic to include just because of the effect that it has on the way that it might skew the data or affect it otherwise. It would be helpful to discuss that more with you.
I also noticed that there was a difference in the level of emotional support that was provided by the staff chaplains versus the students, and I was wondering what might be some of the factors that might be going on there.
That's a good question. You know, a big part of this is what gets recorded in the chart. So I think to answer that question, we have to also kind of think through, is there a way to the culture of a certain chaplaincy department, the way that different chaplains or different spiritual care departments prioritize which should be charted in the medical record, because, you know, as I mentioned, that's where we got that information from. We went back into the visits and saw what the chaplain said they did. So that would be important for us to look through, especially as I mentioned, and it's interesting to kind of follow after Jeanne's presentation, is to, since emotional support really can have a significant impact in helping people make these difficult decisions, it would be important to look at those factors. So I guess to conclude, I'm not sure, but there's some things to look into more to kind of figure that question out.
It also looked as though there was a difference in the level of empowerment of the trainees versus the staff chaplain. So I would be curious as to whether in any of the different institutions, whether the students were being provided with scripts on how to introduce themselves to patients and families, or given things like standardized operating procedures to help them understand their role.
Yeah, I agree. I think that's an important thing to look at, and that's also why I think George and the team wanted to capture also the institutional information, the way that the chaplains are embedded in the ICUs, because I think there are some clear differences. I think everyone here who's involved in the ICU, I think it takes time to kind of get yourself embedded into all the things that happen there, for physicians to start inviting you to family meetings or to be able to participate in rounds that take place. So how people get trained to do that more effectively, I think, is an additional important question to think about.
I think we have 15 minutes left for questions and answers.
Come sit down. Thank you, Sean. So we have, as Sean just said, 15 minutes for Q&A, and because we're recording it, and because it's a big room, if you have a question, we'd like you to stand up by this microphone over here. So you're welcome to queue up and ask your question to anyone on the panel. And why don't you introduce yourself, Anne, and anyone else who comes up with a question. Go ahead.
Well, I'm Ann Noss, and I'm here with Kelsey White. She's the granddaughter of my husband. I'm a retired nurse, but I have a ministry where I take patients who have are encountering cancer and treatments, and I go with them through the whole process. And I have, in my experience, have found that, and this is in Kentucky, at the University of Kentucky is where the treatments have been, that the physician is very uncomfortable ever discussing anything besides goals, 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 and hope. And the feeling seems to be among the patients and the staff that as soon as you turn to chaplains or hospice, hope is eliminated. So they're very, very reluctant to go there. And even though I myself believe very much in faith and the spiritual side of patient care and all that, I've had to almost be rude and saying, I really know that this patient is trying to tell you that they would like to discuss X, Y, Z with so on. And you just have to almost, like I said, be rude. And so I think it'd be interesting to do a study on exactly what physicians, because my husband was a doctor also, and I'm married to a doctor, so I have a interesting inside-outside experience with that. What do physicians really feel is your role, besides what the patients feel? And how this doesn't really balance with what you think, because I think there's a big discrepancy there. Thank you.
Anybody want to comment on that?
Yes.
Thank you, and it'd be interesting. One thing that goes through my mind is interesting to think about whether or not there are kind of regional variations in the extent to which physicians are familiar with the range of things that chaplains can contribute and their ability to kind of take advantage of that.
There are very basic levels of lack of understanding of the role of chaplains and how multidimensional it is, and I think that we have a tendency in healthcare to pigeonhole different types of clinicians and professionals into confining themselves to particular activities, particularly in high volume inpatient settings. So I think part of the problem is that physicians and other medical providers have little if no education on the role of spirituality in medicine.
So at our institution, we've done two things. One particularly within oncology, which is I show up when I was the chaplain there at the monthly orientation for new residents and have 5-minute elevator speech and talk about when they can use us. The other is actually educating in the medical school. So by chance, our module on the kind of intersection of religion and medicine is now embedded in the HEMONC module. So I use evidence-based practice, research there, and teach a lot about these issues within that medical school training. So hopefully over time it will change.
I was going to say something. I forgot what I was going to say.
It'll come back to you, dear.
Yeah.
Jim, did you have a comment? Why don't you introduce yourself?
Sure, I'm Jim. I'm a chaplain at Lurie Children's Hospital in Chicago. I appreciate the affirmation that all of your studies have shown for or the role of the chaplain in decision making. And I was writing down lots of good research questions as I was listening. My question is, in your studies, did you pick up any ways in which chaplains' involvement negatively impacts decision making?
Jim, give an example of what comes to mind or what you may have seen.
Well, sort of we show up and I guess they think that our presence there is, I actually couldn't think of one right offhand, but you know, we have our traditional reactions that people give to us. You're here because we're gonna die, or you're here because they know something that we don't know, or perhaps your presence here stirs up some old wounds that I have connected to my faith, religion, religious background, etc. So more, I guess I'm thinking in terms of perhaps some kind of a psycho-emotional trigger reaction that could possibly be negative. But I just wondered if anything came up from any of your studies where our involvement had some kind of a negative reaction, but I'm guessing not. Okay.
In the in-depth interviews that we did, one of the interesting things we did was focus on those chaplains. Part of the cohort was those chaplains who were not as integrated into medical decision-making. And what I would say, again, not grounded by a lot of data and research because there was a limited number of interviews, is those chaplains saw it only as the doctor's role. They didn't even recognize the term shared decision-making. So it's not quite an answer to your question, but there is a cohort of chaplains who really don't themselves get the difference that we can make. So in terms of a negative outcome or some kind of interesting other flip side.
Sorry, I just want to comment on it too, kind of following up. And I think what I find in my approach with folks, whether it's the inpatient or the outpatient setting, is to empower the patient to make decisions. And so very often my stance is one of, you know, what did you hear the doctor say, and not so much that the doctors are making decisions, so I don't feel left out of a decision making. I guess I would often not be there at the final, if there is some sort of a final decision, oftentimes I am, and with things, but it's much more about empowering the patient or family to make decisions. And I think, because sometimes you have the doctors, I actually come across very few doctors now that are going to make a decision, certainly a nice life, end of life decision, like regardless of everybody. So for the most part it is about how do we help the patient family understand, and they come to a decision, and how do they hear the doctor say what the doctors are saying, and it's that type of intervention. I also was going to just piggyback on what was said earlier on. I do think that, I think for chaplains we need to take on board a bit more of a sense of our authority and be able to be there and to be present and not abdicate in any shape or form. And especially with the physicians or with any of the medical team, that if we see ourselves as part of that medical team, they then will see us as part of that medical team. And with our physicians and with the way things are going, especially with younger physicians coming through, many of those, they all now want to be called by their first name, not by Dr. So-and-so. And they're much more inclusive maybe than some of the physicians in the past. So I think there's a change there, and there's an opportunity for chaplains to claim their authority.
Thank you.
Jim, let me just make a comment actually, and that is that the methodology of the studies that we heard wouldn't have necessarily brought out the information in response to your question. And so it may be that for us to have a better understanding of when chaplains' involvement actually is not helpful. We'd have to be more intentional and use a different method. And while I say that, let me put in a plug for a study that did actually ask that question. It's a study by Pamela Donahue and colleagues at Johns Hopkins Children's Hospital, and it will be the subject of a webinar journal club session, I think in March this year. And somebody who has the evidence-based chaplaincy reader, hold it up. Right? Who's gotten ones this morning? Bought the reader this morning? Some people have bought it, right? So
right
there's a book for, there it is, okay, Martha's holding it up. There's a book for sale outside, so here's a little shameless commerce. So this is actually the first time that we've had a reader for chaplaincy research. There's 21 articles in the reader about chaplaincy research, and this article about Donahue that I just mentioned is in there. And part of what the team from Johns Hopkins did was actually talk to parents whose children had been treated at Johns Hopkins, and among other things, they actually asked parents who had not asked for a chaplain visit what it was like for the chaplain to show up. And so some of that ways in which people had a little bit of a negative reaction when the chaplain had shown up and they didn't know exactly why that was happening. That's the one study I can think of where we see a little bit of that. Sharon? Yeah?
Yes, good morning, everybody.
Speak up.
Speak up, yeah?
My name is Sharon Cozy. I'm a APC board certified chaplain, and I'm full-time at Mount Sinai Trauma Center, Mount Sinai Hospital. And I wanted to make a comment and then, have a question at the end. Because we see so much trauma there, I sometimes wonder if the doctors, and I know we were talking about in the first presentation was partially about oncology and palliative care and so on, how much of a comfort level, if at all, some of the physicians have when there is death involved. What I've seen is that some of the doctors, residents, and so on really don't have an experience with anyone close to them dying. And from my training here, I know that they are not trained to handle what we're trained to handle. The other part of that is some of the older physicians are more seasoned, and I can say that because that includes me as far as being seasoned, may not feel comfortable in talking about death and the dying because, of course, as we get more seasoned, that's something that we think about, but we're trained for that. So I sometimes wonder how they're impacted in seeing the traumas and the death and the dying and so on as far as their own mortalities are concerned. So not that I'm offering suggestions for your studies, but that might be something to consider, as you all move forward with your research. Because we, as chaplains, we're there for everyone, not just the patients, but for the staffs too. So that would be my question.
Sharon, thank you. Sean, do you want to say anything about that?
Sure.
What helps physicians be?
Well, in general, what helps all of us is education. So to the extent that we can expose trainees from different backgrounds to death and dying and ways to take care of ourselves in the process of caring for patient populations who may have tremendous suffering and high mortality. We offered resiliency training for providers working in the palliative care arena over the course of several years, and a group of trauma providers from Stroger participated in that. I think we've done a better job in some areas of medicine at exposing our trainees to palliative care, but I think surgery is an area of medicine where I think they need more help and more dedicated curricula for palliative care.
I appreciate it.
Yeah, so I mean, Sharon, part of what your question touches on actually is what we know are actually notable and concerning rates of burnout among our healthcare colleagues, including physicians. And so it's an area for kind of further thought and investigation as to what extent, what are the best ways to kind of help our medical and other colleagues with the situations that contribute to compassion fatigue and burnout, and to what extent are there appropriate roles for chaplains in that kind of work, and then to what extent can we do research to kind of document it. So appreciate that.